All right, let's get going. It's a complete pleasure to introduce Colleen Grogan, an old friend, colleague, scholar. Colleen is the Deborah and Edgar Jannotta Professor at the University of Chicago at the School of Social Services. Her first book is a wonderful book, Healthy Voices, Unhealthy Silence, about advocacy and health policy for the poor. Her latest book, Grow and Hide, we'll have a panel at 4 o'clock. This afternoon on Grow and Hide. I know many of you will be there. I hope as many of you as possible can come. Colleen is an authority on Medicaid, on opioids, and now has this large project of financialization that she's going to be just exploring with us. This is one of her first presentations on it. Colleen's been very active in the health policy community, helping to build the community, was editor of our flagship journal, the Journal of Health Politics, Policy and Law, for 6 years. And I'll just say one more thing before, so I don't embarrass you too much by going on, which of course I could. Colleen is one of these rare scholars who combines real rigor. If Colleen's written it down, you can take it to the bank. It's been carefully researched and you can be confident in it. But she never loses sight of the larger values that she's invested in. She's always thinking about social justice and about how to make the world a better place. Healthcare almost is designed to make you a cynic, and many people give in to irony because that seems to be the only way to cope with all the things we see, as you're about to see. But Colleen never gives in to that. She always hangs on both to her rigor and to her values. And for that, I think she's really one of the most admirable people in the field. And having, I hope, embarrassed you thoroughly, welcome to Brown. Oh, and let me just say a quick welcome to the Stone Fellows, our first time together. This is very exciting, this new program we're launching, and the Stone Undergraduate Fellows are here to see you as well. So welcome, and we'll have much to say later about that as well. Colleen, welcome to Brown.
Oh my gosh, thank you so much, Jim. I might stand a little bit and sit down. It's a little bit easier for me to talk and engage with you if I stand. Thank you so much for that introduction, Jim. That did embarrass me. It was very complimentary. Yeah, I can only aspire to really remain true to that. Social justice is dear to my heart, but it is a struggle in healthcare. And I think that this talk will unfortunately kind of exemplify that struggle. The title of this talk is The Financialization of Health and Health Politics, which is actually kind of a lot to cover. But hopefully I'll give you kind of the broad contours of what I'm thinking about, and then also try to get into some specifics. As Jim said, this is kind of the first talk where I've tried to put the two together, but I have given some talks on financialization of health and financialization of health politics. So now I'm trying to kind of say these things, not surprisingly, are related, and want to think about how they're self-reinforcing. So I want to start by just acknowledging some of my co-authors. So on the health politics side, I've been working with Miriam Lageson, and on the financialization of health side, I've been working with an assistant professor at University of Chicago, a colleague of mine, Jannotta Brock, and Victor Roy, who's actually a postdoc at Yale University. He's an MD, PhD in sociology. So I often start this with thinking about what is private equity, and I've kind of broadened the view to think about what is financialization. But I want to start today with kind of where I started, because I think that it's sort of where we're at in some ways in the news. And so when I first started thinking about private equity, I was actually working on that book. And I was into chapter 8, writing about what I call in chapter 8, capital health policy, and kind of like, why did hospitals in the US become so dependent on the capital markets? And that took me into some of the policies around 1965 and kind of moving forward. But as I was doing research for that, and this was embarrassingly back in 2017, so it was quite a while ago, and I kept coming across writings that it wasn't so much in the news then, it was more in financial industry kind of newsletters. It was more talked about in the financial industry, and private equity was everywhere in 2017. It just wasn't in the news quite as much. It was kind of just beginning. And as I was reading about it, I was thinking, I'm not a finance person, and I think I'm just not getting it. Because if the way that they're acting is true, I don't understand how this is possibly legal. Because it just was some of the behaviors were so egregious. So when I studied it more and realized actually it is true and it is legal, I was really worried about private equity and its role in the healthcare system. And so when I started this project, I thought, okay, it's sort of how is private equity and the private kind of private investments impacting health politics. And so it was really focused primarily on private equity. So I want to start with that here, and I think where most people are worried about with private equity is on the leverage buyouts. So basically, you all have probably heard this story before. They acquire a healthcare company. They acquire it. It's financed heavily by debt. So really, very little equity is put in and highly leveraged by debt. And they take over when they acquire the company, they're focused very much on what's the value proposition in the short term, right? So how can we increase value, which I put that in quotation marks because in health policy, I think increased value should always be about like increasing quality of care or increasing access to care, or lowering the cost for the same value, right? But in this case, it's really just about how can you increase the value, the capital value of the company, right? I mean, and that makes sense in finance, that would be your focus. But so when they say, what's the value proposition, it's really just, can we turn around, can we sell this company 5-7 years out for quite a bit more and give a profit back to our investors, right? And they can exit. So that's the primary strategy of private equity is to exit in the short term with a high profit margin, pay off their institutional investors, and obviously earn money for the fund. Huge tax advantages that they can take advantage that they do take advantage of, and the carried interest. You might have heard about that a few years ago. It was very much part of the debates in Congress. So the growth in the healthcare field in private equity, and there's been a couple books that have come out in the last year as well, The Plunders, I don't know if any of you heard of that, and most of that book is broadly focused on private equity and its role in the US, but much of the book has healthcare examples. And I think that's because in the last decade, most private equity funds and investment firms have had healthcare as one of its major investment portfolios. So it's of all of its investments, healthcare has been one of the top two. So we've seen significant increases, and it's not just in deal volume and the amount of capital invested, but it's not just in one sector. So they started out in nursing homes and actually dialysis, which I'll return to that. But now today it's kind of actually hard to find a sector of healthcare that private equity has not yet invested in. So behavioral health systems, of course, pharmaceuticals, medical credit cards, etc. Okay, so just basically, why is it that healthcare was such a major investment opportunity for private equity firms. Private equity tends to like healthcare for the reasons I list here on the board, and this is actually coming from an article written by a woman, Robbins, and a couple of co-authors. She was from a private investment firm, and she wrote this article back in 2008. So a long time ago now, and it was kind of at the beginning of that big increase I just showed you. But it was at a time, again, when it wasn't on people's radar screen. And she wrote it in one of the biggest impact journals in health policy, which is Health Affairs. And it was like sort of one of the only private equity articles, the first private equity article to be published in 2008. And so it was very new for people in health policy. They weren't thinking about this. And what she said was, well, we're attracted to healthcare because there's not a whole lot of regulation, which is really surprising to people in health policy because they always talk about healthcare as being heavily regulated. But the point she was making is that in the areas where we can invest, there's very little regulation that hinges on what we can do. So in the delivery model, in the delivery system, in terms of reforming management styles, very few regulations actually that would impinge on what private equity could do. Stable reimbursement rates, and what she was talking about there was really public insurance, that Medicare and Medicaid, even, she didn't really mention Medicaid so much, that comes later, but nursing homes, of course, were primarily Medicaid, and they were the first investors, so that I think is actually quite interesting. But Medicare, very stable reimbursement, it's an entitlement, so the way they saw it is, well, we know we can look at the rates, we can do our due diligence and figure out whether we can make a return on that reimbursement. They also are very, very good at figuring out loopholes. So they have a lot of capacity to do significant due diligence prior to making an acquisition. And in that due diligence, they hire consulting firms who typically are focused solely on healthcare. Oftentimes people in these consulting firms come from a long-standing positions in government. They really understand public insurance very well, and so can run the data and talk about, well, and they know reimbursement schemes. So there's, and I call it a loophole, but it is legal, and they can leverage areas that reimbursement has some play. And then market size growth. So just demographics are very much on the side of increasing demand. So an aging population, private equity saw that, knew that demand was going to increase. And then most importantly, in terms of market size growth, this gets at really public funding. This is also in 2010. So she wasn't really talking about this, but in 2010 we start to see an increase, and it really takes off after 2014. And I don't have a study that says the ACA increased private equity investments in healthcare, but if you just look at the areas in which they really shifted into acquiring firms and increasing their investments was very, not only, so they invested throughout healthcare, but they were very interested in markets that now had new coverage opportunities from the ACA. So behavioral health is a perfect example of that. Prior to the ACA, behavioral health was covered in commercial insurance and somewhat in Medicaid, but it was significantly expanded from a number of federal policy reforms. One, the ACA saying it was mandated under the essential health benefits that behavioral health coverage had to be covered.
Why don't you just say what behavioral health is?
Sorry. So
deep in there.
Behavioral health is kind of a new term that brings together mental health care services and substance use disorder services. So thank you for that, Jim. So it's a very intentional use of a new term because those systems have been siloed, and the idea is that we really need to have integrated healthcare for people because substance abuse and mental health are co-occurring so much of the time that we should think about this as behavioral health services. And that is kind of how it was promoted in the ACA as well, that insurance companies were mandated to cover mental health and substance use disorder services. Now, I say mandated also kind of with quotation marks because state governments could define what those mandates look like, and managed care organizations get to decide exactly what coverage for those areas look like. So lots of variability under that hood, but they have to cover it. If that makes sense. Getting into the weeds here. But private equity has moved into investments in the behavioral health sector in a major, major way. And most of the interest was because, well, coverage is guaranteed. We know there's reimbursement now, right? So it's really public funding that was driving these private equity decisions. The other thing that I just want to mention on here is fragmentation is really interesting because in health policy, people that have worked in health policy for years, fragmentation has always been a serious concern, not just because it really hinders good continuity of care for patients, right? So if you have a really fragmented market that doesn't, just as I said, mental health and substance use disorder are siloed, they don't work well together. Primary care, physical health is siloed from behavioral health, which is the case. But even, you have primary care docs that don't have seamless relationships with specialty care. Like we keep talking, we've talked about this problem forever, about how do we create integrated health systems and continuity of care, right? So fragmentation has always been talked about a real problem and a real challenge because there was resistance within the marketplace to create integrated systems, right? Private equity came in and said, fragmentation is an opportunity for us because when we can come in, we see opportunities to acquire individual fragmented systems of care, these individual companies, and we have a strategy for that called roll-ups. And that it just essentially means we're going to acquire lots of small, again, back to the behavioral health care example, we will acquire small mom and pop treatment centers, which was very much how behavioral health marketplace, what that looked like, especially in 2010. A lot of small family-owned treatment centers in that space. They would come in and acquire, maybe 100 different companies within one region, and then do that across many different states. Now, what's important about this strategy is that when you acquire small companies that don't reach a certain monetary level, it doesn't enter into the radar of the antitrust, of the FTC, right? So the Federal Trade Commission, to think about antitrust regulation. It's only in the since the Biden administration that the FTC has started to say, no, we're lowering that threshold so that we can begin to look at roll-ups. But they were able to continue with acquiring and doing the roll-up strategy for the last 2 decades prior to this recent administration. Why is that important? That's important because it gives them, over time, if you keep rolling up, it's just they have more and more monopoly power. So it really actually is an FTC concern, and it's a huge concern about anti-competitive behavior, right? So they're able to gain significant market share, and when they gain that market share, they increase prices, right? I'm not a big fan of kind of economic analyses of healthcare marketplaces because I don't think that they work as a competitive marketplace. But when you think about monopoly power in healthcare, it does work just as economists would tell you it works, right? So in this case, I think it is important to understand what was happening here and why it's such a logical strategy for PE. Okay, so my argument when I was looking at the role of private equity in healthcare was to say, well, There's significant growth in private equity investment has led to the financialization of healthcare. As I said, sort of by 2020, private equity is everywhere. It's almost in all sectors. So I was thinking about that just as sort of financialization. And then because private equity investment returns are dependent on public funding of healthcare, the financialization of health politics is occurring, right? That they have an invested interest in and maybe maintaining the status quo, but also kind of making sure that health policy is shaped in ways that are favorable to this existing financialized system. And then these feedback effects are going to continue to grow the financialization of health politics. So that was kind of my starting argument. And just on the public funding side, this relates to the book later on this afternoon, but people think public funding, many people don't realize, so for those of you who don't think a whole lot about healthcare, public funding has reached 60% of total national health expenditures in the US, and that's actually, I think, a significant undercount. But that, even just by looking at federal accounting statistics, that's a minimum of what's happening. So it's quite a lot of money in the healthcare system, even though we think about it as predominantly private, is really fueled by public money. So is there anything different about thinking about financialization of health politics? Like now I've made this argument that the financial industry or private equity firms are really involved in healthcare. They now want to influence health policy. Well, maybe that's just another interest group along with all the other interest groups in healthcare policy that have long been very powerful in healthcare. So how would the financial industry be different from medical provider interests or the pharmaceutical companies, or even big business has long played a role in influencing health politics? And I argue that the opacity of private equity, the role that it plays in politics, makes it significantly different. So I want to spend a little time talking about that, why that, what do I mean by that, and how is that perhaps different? And I lay out 6 main factors that I think describe private equity's role in health politics. And that's owner, opacity, rhetorical power for positive framing, blame avoidance, hidden coalitions, lobbying activity, although it's really pretty unclear, and I'll talk about why. In part, that's because of the lack of data and opacity again, and then feedback effects that continue to grow political power. So back to that other argument. So let me just start with ownership. So the first thing to say about private equity, which I probably should have started with this, but I'll return to it, is it really emerges so significantly today because of massive deregulations that occurred in the banking industry around banking regulations, and really starting in the 1980s, but even a little bit of activity in the 70s. Reinforced in 2000. So I'll go into more detail about that. But because of that lack of regulation, private equity, there's actually very little good data. They're not required to report data to the SEC as other public firms are required to report. And so where most of us get data on private equity is from a private data company called PitchBook. So if you've ever seen, like my slides were from PitchBook, most health economists that now do research on the role of private equity in healthcare is based on PitchBook data. Now where PitchBook gets its data is it basically scrapes the internet to get that data. It doesn't go to SEC. and just say, oh, what is PE doing? Because PE is not required to report that data, right? This is just so important, which makes it very, very hard to study the impact of private equity in healthcare, in any area really, because the data is pretty spotty. Now, we have some amazing academic researchers out there today that can triangulate what PitchBook is saying with some other data sources, and they'll do their own web scraping. But if you look at the PitchBook data, PitchBook is able to say there was a deal made and they acquired this company, but sometimes the deal amount is just not disclosed. So we have some deal amounts for about half the number of deals that of companies that have been acquired, for example. There's also all of these complicated ownership relationships around subsidiaries, and that's really hard for PitchBook to get a handle on. So the data we have around all the subsidiary ownership structures is really not very good in PitchBook at all. So I just want to give a couple examples of why that lack of data is problematic from the politics, like in the political arena. And one is, I just want to give the case of nursing homes. So as I said, nursing homes were one of the first areas that private equity really moved into in a major way. Nursing homes, even though they're predominantly funded by Medicaid, are for-profit. Most of them are for-profit nursing home chains or nursing home companies. And actually, ironically, if you know healthcare at all, usually nonprofits will be much more likely to take care of Medicaid patients or take care of the uninsured. And nursing homes, the relationship is switched. So the for-profit companies are much more likely to take care of Medicaid patients. It's just a little bit of what's interesting about that is private equity could see that the for-profit nursing home companies were figuring out a way to make a profit on Medicaid. And so I think that's part of the reason they were initially interested in the nursing home market, because they could see ways to increase value in a short period of time. So they started this entry in about 2000, and by 2007 there were a number of hearings in Congress about private equity-owned nursing homes, because a number of stories started to emerge in the media, and I think kind of different, a few academic researchers in long-term care started to publicize their own findings about what was happening with PE-backed nursing homes. And so Congress had a hearing, and there were primarily people there talking about some of the real concerns happening in nursing homes. But the private equity was not in the room, so the actual firms were not in the room. The for-profit nursing homes were in the room, of course, in the hearings. And what they said was, yes, there's a few bad apples, but this isn't characteristic across the board. And the problem is that at that time, by 2007, they were all investigative anecdotal reports or qualitative studies of what was going on. And so it wasn't persuasive to Congress, right? So this lack of having having disclosure rules also plays into the politics, where the firm being accused of bad behavior could just simply say it's a few bad apples, and the data support a few bad apples, but nothing more than that. It was really hard to look at it from a systematic perspective. By 2021, we have this really important article by Gupta et al. That was able to look at nursing home data over 20 years. They did this really extensive data collection process of figuring out PE-backed versus non-PE-backed nursing homes, did a difference in difference analysis, a very sophisticated quantitative approach, and found that PE-backed nursing homes were more likely to increase mortality than non-PE-backed nursing homes. So it's pretty hard to find effects on mortality. That's a that's a pretty, that's a dramatic outcome, right? You're actually saying in these PE-backed nursing homes, death rates are going up, right? So hugely significant. Again, more hearings in Congress. There have been some reforms that came out just in the past year that said, so what Gupta et al. Also found was that what led to the higher mortality rates were reductions in the patient to staffing ratios, and that especially nurses that most nursing homes had on staff were the number of nurses went down in PE-backed nursing homes, and just the number of overall staff went down in nursing homes. And so you just had more patients and fewer providers to take care of them, and that did impact the quality of care that was being provided. So now Congress has finally responded 20 years later to say, okay, we think there should be some standards around staff to patient ratios. Okay, so we do get some action, but the action isn't pointed towards private equity, right? The action is pointed to a regulation around a very specific finding about the ratios, which is important. I don't want to minimize that. When in my interviews and talking to some of the people that are involved in the space of private equity and nursing homes, but also just more broadly in healthcare, and this one person was from a private equity firm, and he said, that's just a joke. We don't even care about nursing homes anymore. That's so late to the game. So we're moving on from that. So that was, to me, was very heartening from the data perspective, right? Like if we take 20 years to be able to come up with a definitive study about bad behavior, that's kind of too late. So more and more people are making these arguments around the importance of disclosure, but you can see how that really gives an advantage to private equity in this space. The other thing, other example I just want to point to is MedPAC is it's the Medicare Commission that oversees the Medicare program. And Congress will request MedPAC to do particular reports for them on topics in healthcare related to Medicare that they're concerned about, right? And so in 2021 report, MedPAC was requested to look specifically at the role of PE in the Medicare program. And so when they tried to look at the role of PE in Medicare, they were stymied by the lack of data. So they basically said, well, it looks like PE is only involved in about 8% of health systems and about 2% of long-term care and nursing homes. And in the physician market, it might be around 8%. So they sort of said it's just not that high. And the evidence to date is really mixed about the effect of PE. So even though, so they would say all this, but at the same time, almost in every other paragraph, they would say, well, but we don't really know because the data is just really unclear and uncertain here, right? Nonetheless, if talking to another colleague who is very much involved in working on Capitol Hill and health policy, he said, oh yeah, I read that chapter, and basically MedPAC said we shouldn't worry about PE, there's no worries. And I think that was the concern about this report, was that the lack of data, and they're very cautious, right? It's primarily people there that look at quantitative studies, and they only want to say what the evidence supports. And to even in 2021, the evidence, even though the evidence is just minimal and not sufficient, didn't support any concerns in PE, right? So it's a problem. So that all plays to the power of PE in the political realm, right? So the other area is rhetorical power and positive framings, and this is what all actors do in kind of any area, I think, right? Like they want to, if they're trying to sell a good or they're trying to influence people, they will create a positive frame. So there's nothing surprising here. And these are just examples from the American Investment Council is the lobbying group for a number of private equity firms. So this isn't all that surprising, but what I will show you later is that the reason this rhetorical framing, I think, is even more powerful than maybe other interest groups is that it kind of is able to leverage the significant problems in our existing healthcare system to its advantage, right? So most people that look at the US healthcare system in the US see major, major problems. And so when a new actor kind of comes into the space and says, we can provide innovation, we can finally be the disruptor for change, it's very difficult to say, no, we don't, we don't want your involvement here because you're going to do bad things. Their response is, well, how could it be any worse? And for those of us who know about healthcare, it's hard to argue against that. So the kind of the problems in healthcare, I think, really bolster this rhetorical frame. The third factor, I think, is blame avoidance. And here, this is really, really powerful, I think. And that is that because private equity is hidden behind the companies it acquires, and again, there's no data on this, so you probably, when you go to your provider or your physician, you probably don't know whether they're part of a larger healthcare company that's backed by private equity or not, right? I mean, I don't, unless I really try to do some digging. Like that's not what you're going to the provider because you have other concerns probably than thinking about their financial structure. So when there's a problem, when something's happening to you or your loved one in the healthcare system, you tend to blame the provider, right? Or the company, the hospital, the nursing home, whatever it is. You don't think to blame the financer behind them. And again, I think this plays to the power of private equity because it's this blame avoidance, blame displacement. And I should say, I think there's no incentive for policymakers to make that direct connection, and I can kind of return to that. And then the fourth thing is what I call kind of a hidden coalition or a hidden financialization coalition. And so this is where I had to take pause about, is it private equity or is it something broader about financialization in healthcare? So all of these actors, provider groups, insurance companies, pharma, business, advocates, they've been involved in health politics for a very long time. And when you look at some of the stories related to private equity, such as the nursing home story I mentioned, or if any of you read, there was an expose on Hahnemann Hospital in Philadelphia that was really heartbreaking and talked about interviewed providers that felt like they couldn't offer the care they wanted to anymore. They were so unhappy with this private equity firm that came in. You sort of think, well, why is it that provider groups aren't coming out more against the financial industry involved in healthcare? We're seeing a little bit of it now, but by and large, not a lot. Right? We don't see a whole lot of mobilized groups out there against private equity yet. We don't see insurance companies really speaking out against PE. Pharma, no. Business, no. Even advocates. There's not a big. There's one advocacy group called the Private Equity Stakeholders Group, but I couldn't find any real, big advocacy groups. Sometimes unions will get involved because they're concerned about, what private equity is doing in different companies. But unions benefit from these big, the pension funds that are public investors in private equity. So what I'm getting at is I started to realize how all of these groups maybe the reason they're not speaking out against private equity is they are also heavily entwined into the financial industry and the financial markets themselves. So that's where I want to kind of pause now and think about the financialization of health, because I think that's really what has bolstered up this kind of hidden coalition. I do want to say that consultants and lawyers, maybe they've always been involved in health politics, but they seem, they're particularly involved in the private equity movement into healthcare. A number of these major consulting firms only do PE business, which I found kind of striking, and that seemed somewhat new to me. So I kind of put them in this group as a new group. Some of the people I was able to interview do have concerns about what their clients are doing. But when I said, well, what do you think? Should government regulate? Should government? And many of them had been in government and now work in these consulting firms. They're very reluctant to say, well, yes, government should regulate. Of course, because their business now depends on this major client of theirs. So there's a bit of a conflict of interest there. Lawyers, I mean, now there are most law schools around the country, have tracks where lawyers can focus specifically on litigation in the financial industry, but particularly working for private equity, private investment firms. So this is a major new area, I think, relatively new area for lawyers to move into, and it's particularly problematic when you think about trying to fight against some of the activity of PE from either in bureaucratic politics, such as the FTC, or some of our other bureaucracies, because we just can't compete against the amount to which they can lawyer up. So I can go into more detail about that later. So this is from, we have an article that's just got accepted into New England Journal of Medicine called The Financialization of Health. So I'm going to draw, and I wanted to just acknowledge my co-authors there, that this is drawing from the work of that paper. So what we say in that paper is what's happening with the financialization of health, what's important to realize is you have these financial actors that have moved into health. And that's really what I've been talking about so far, right? And I've been just focusing on private equity. But what's important to realize is it's not just private equity. There are these other financial actors that we have to also kind of take account of. There's also the financialization of healthcare entities themselves. And then that all filters down into creating more debt, and the need for possibly, the way we've responded is more credit for consumers to alleviate their debt. So let me just kind of go through that model a little bit. So the role of the financial industry, again, most of us have focused on private equity, and so that's really what's on this slide. I think I've already gone over that. And the primary concern there is about acquiring other companies, right? The kind of the leverage buyouts. But there's financialization beyond private equity, which I think is really important for us to take account of. And this has gotten some news, but for many people is a bit in the weeds. And so most people don't realize the role that REITs, or real estate investment trusts, have been playing in the healthcare space. And so what these REITs will do is acquire healthcare properties and then lease the real estate back to the healthcare facility. And Hanneman, both private equity moved in, and when they bought that hospital, and also a REIT bought the property itself. So it both is changing the management structure of the hospital, and a separate financial instrument is buying the property, and so making that hospital pay rent back to this separate investment trust. Today, REITs own 8% of US healthcare real estate, hospitals, senior housing facilities, medical office buildings, skilled nursing facilities. I mean, they're they're moving, again, just as private equity did, across all sectors pretty much that you can think of, where they can see a return on investment through the investment in the property. Okay, so that's, there's lots to say about each one of these instruments, but just kind of giving you the overview to understand that it goes much beyond PE. So the next one is what you might think of as kind of indirect ownership. And here, what happens is you have financial actors that obtain shares in a healthcare entity, right? So it could be a hospital or a nursing home again. And that often means early stage investments like venture capital or on the stock market. So we haven't talked about venture capital, but that's hugely important in the healthcare space, especially around healthcare startups. And if I had time to get into the interviews, I'll tell you a little bit about that. They're now investing in venture capital as in exchange for early equity, right? So they still get a portion of the firm, a portion of the ownership, by making this early investment, and then exiting after a period of time, typically for PE to then acquire the firm. So that's a typical kind of capital trajectory, right? So venture capital has increased nearly eightfold in the past decade, and it's reached 28 billion by 2021. So pension funds, mutual funds, hedge funds, they've also become heavily entwined in the healthcare system. Healthcare has become, one of the most common targets for hedge funds now. And they do things that are very similar in some ways to private equity, but again, they acquire kind of a portion of ownership, maybe not do a whole leveraged buyout. And that capital can really change the behavior of the healthcare entity itself. Okay, and then, I don't know if any of you saw this just last weekend. I just wanted to put it in here. I don't want to pretend that I'm an expert on what's happening with insurance. Apollo is a private equity firm, an private investment firm. And, but I just think what's important here is the article is pointing out how they're behaving like banks, but they don't have to operate under the same regulatory structure as banks. Again, taking advantage of their unique status as private investment firms. But they're constantly coming up with kind of new financial instruments. So that's why when I saw this article, I thought, oh, of course, it's just like yet another evolution. That's hard for us to keep track of. So that's just a broad overview of financial actors. But what's happening when I say financialization of healthcare entities? What do I mean by that? So I want to just explain what that is. So there's a lot of behavior now of healthcare companies, healthcare entities behaving like financial firms themselves. And so I want to focus first on nonprofit hospitals, and I really specifically highlighted that nonprofit hospitals are involved in this behavior. And again, perfectly legal. They moved into the capital markets, starting in the 70s, really significantly in the 80s, and this is arguably just a kind of continuation of that. But what I've kind of tried to highlight here is that they too pursuing mergers and acquisitions to increase their market power. But most importantly, they launch investment arms that are part of their broader business strategy, their business portfolio. And some of the largest nonprofit hospitals had significant investment losses in between, from 2021 to 2022. And people were kind of concerned about, well, what's happening with these large nonprofit hospitals. And a recent study was able to show that it wasn't due to, because, quite frankly, the hospital themselves said, well, it's, increased demand, more Medicaid expenditures, we're not getting the reimbursements we need. But when they looked under the hood of what was really going on, what they found was there was a 164% decline in profit margins, but that wasn't due to healthcare expenses. It was due to investment losses. So they were making significant investments on the investment arms, and they just weren't good investments. And they lost a lot of money and reported this, but again, we didn't see the public, right, didn't quite understand what was happening. And nonprofit hospitals, especially at the state level, wanting a little bit of a bailout, right, for what we now know are their own investment losses. Okay, so the other example I wanted to give was, this I think is really important. Health insurers and pharmaceutical companies are another example where really common vehicle now for distributing capital is what's called share repurchases, or also known as share buybacks. So what this does is companies buy back their shares to increase the value of the remaining shares. That's a very little nutshell is what a share buyback is. And it's become a really important strategy for a number of companies, most importantly pharmaceutical companies and again, insurance companies. And so, in health insurance companies, they had $7 billion in profit in just 2022 alone. It was nearly like a 300% increase. But of that, they allocated $26 billion to share buybacks in that last year, right? So they're funneling the capital to increase the value of their stock. But it's one of these things around value that's usually problematic, because you want stock values to increase because there's something about the real value or production of the company that's adding value, and that increases the stock. Here it's just this artificial kind of play with the shares, right? And same thing with pharmaceutical companies. They spent $87 billion more on buybacks and dividends to shareholders than on research and development. That's pretty striking. Like, they say the main thing they're doing in terms of investments, right, is research and development. But it turns out that's not true. Just want to give a call out to my co-author, Victor Roy. Just finished a book on, if you want to learn more about what's happening with the pharmaceutical companies, Capitalizing on Cure, was published in 2023. Okay, so how does that, right? So we have the financial actors coming in. We have healthcare entities themselves acting like financial firms. How does that filter down into what's happening for individuals, for you and I in the healthcare system? So a lot of this behavior has resulted in significant increase in prices. The roll-ups that I talked about, but also just, more out-of-pocket costs and rising premiums. So the reaction to that has been for physician practices and hospitals to partner with financial institutions, and they're specifically marketing to individuals that have bills to pay, out-of-pocket bills, medical credit cards, and installment loans with pretty steep interest rates, right? Now you think, well, this is probably not such a big business that people have to get these medical cards, but it's become a really big business, these medical credit cards, multi-billion-dollar business for private equity firms who have also invested in medical credit cards. So it really is impacting. I think we were all hopeful that the ACA would, a huge motivation for healthcare reform in 2010 was that personal bankruptcies due to medical debt, that was a huge motivation, that we had to do something about the fact that the main reason for personal bankruptcy was medical debt, right? And it really, I think, filtered into the arguments that we were having at that time and the need for more coverage. Here we are in 2023 with, medical credit cards, and medical debt is still the largest contributor towards personal bankruptcy. So something has gone seriously amiss, right? And I would argue that a big part of the reason for that is the financialization of healthcare. So,
Colleen, maybe wrap up this.
yeah. So just want to say that this obviously isn't happening all on its own, right? The state is playing a major role across all three levels, right? And I could, go into more examples. Deregulation is contributing to that, reliable public financing that I already talked about, and then social policy. Here's more specifics about deregulation and the absence of oversight, which I will just kind of skip over. I already talked about financing. I just think it's important to kind of point out how the lack of a cohesive social welfare system, contributes to the reliance on credit and creates these high levels of household debt. And there's many examples of this in housing and in education, but clearly, as I just talked about, it's significant in the healthcare realm as well. And so we have this, kind of two-sided policy dynamic happening where the state creates an unequal social welfare system that leads to more vulnerability and debt. And then the state also promotes household reliance on financial markets to access capital to in the absence of these protections, right? So it's sort of leading consumers, due to its lack of protection, to the financial markets themselves. But when a recent proposal by the Biden administration around medical debt was to say it won't lower your credit rating, but that in itself suggests it's okay to rely on, credit cards, but it won't, if you can't pay it off, it won't lower your credit rating. And this all, this is kind of back to my main argument about health, the financialization of health is related to the financialization of health politics, right? So you have these state policies I just talked about that are promoting financialization of health. The healthcare industry, health entities are activated that influence health politics. These new health politics shape then health policy. So I'll stop there. I had some interviews to share with you, but that might come up just as we have a discussion. So why don't I stop there?
Wow. All right. Well, that's a steep mountain to climb. But let me start with the obvious question, and then we'll turn it over to the rest of the audience. I can't imagine. Well, so what's a policymaker to do? And I would imagine that state policies are probably the way this will first be confronted. A state like Rhode Island might think, okay, we have a limited number of hospitals. We can count the number of things. What's the arsenal? Where would you, besides reading your book and getting the data, where do we begin to think about addressing all these things? I mean, I see three different huge problems that you've implied. One, we're eroding our healthcare system through financialization. Second, we're hurting access. And third, we're hurting quality. All three of those things seem to be going on, putting costs aside. Is there a beginning toolkit that we can think about for policymakers, or is it too soon in the project to be there?
I think there is a toolkit that has been offered. Ziri Song at Harvard University in health policy kind of has one that he's offered. I think it's really reasonable. It's sort of like this 5-point plan on reforms that could be implemented to regulate the role of private investment in healthcare. It starts with disclosure rules. It has something to say about antitrust changing how it is able to litigate, and some of that has already been implemented. So a very, very important recent suit that just came out was against a particular, oh goodness, I'm forgetting the company, but it was a PE-backed company. And basically what the FTC said was PE is implicated in this lawsuit, right? So it was the first time that it acknowledged, we're not just going after the company itself, but we're going after the role of this investment firm in the M&A activity that's leading to this anti-competitive behavior. So it's trying to get behind that, kind of dealing with that blame avoidance problem, right? That we're blaming the front end company for the problem when it's really the actor that's doing the behavior we're concerned about is the investment firm. So that, I think, is pretty significant. It was, who knows what's going to happen. I'm really curious about that. What else? So those of you who, you should look that up. My concern about that is, it still allows, it doesn't deal with all the other financialization of health aspects. It says it's focused on private equity. There are some real bad apples, and if we create a regulatory structure around that, we can weed out the bad apples and then have benefits from the good things that private equity can provide. Now, so I think, so I want to go back to that, the good things private equity can provide are part of that. But to answer your question about, what do we do? It does feel very daunting because I'm making this argument about how it's really infused into the politics. And I hadn't quite one example. So part of these factors, the reason they're so successful, if you just even look through the first four, which is all I got through, part of the reason these factors are so successful is that they just keep the private equity, the role of private equity in the healthcare system completely off the political agenda. So there aren't a whole lot of examples to look at in terms of how has, when private equity has really been implicated, how has that played out politically? So the best is the nursing home example that I gave. But the other one is surprise billing. Because most of the actors that were involved in surprise billing, so do all of you know what surprise billing is? Maybe not. It's when the most, I'll just give you one example that was really the most concerning in Congress and led to the No Surprises Act. And that was that when you, even insured individuals would go to a hospital, they would look up, is my hospital under my network if I'm in a managed care organization, which almost all of us are, and they would check that out. They'd make sure that their surgery was covered before they went in and think, great, I'm covered, no problem, I'm going to be set. They're in the operating room, and the hospital, the surgeon brings in a consultant from a physician, an ED consulting management company. When they bring in that consultant, the consultant itself comes from a separate company and is paid by a separate company. So there's a surprise bill associated with that consultant in the emergency room when that patient is getting surgery. So what was happening is a number of patients post-op were getting these huge, not just little bills, like up to $15,000, $20,000 bills from this consultancy activity that was happening when they didn't even know about it. And this was, I think, a really egregious activity and very concerted effort on the part of the investment firms that bought these ED management companies to say, we can do this legally, you're going to get into the hospitals will get a kind of, not a kickback, but essentially a kickback, right? Like there's a financial incentive for the hospitals to also behave in this, to also be part of this behavior. And we'll just directly bill the patient, right? right? So it was just egregious. So it did actually get finally onto the agenda of Congress to say, we got to do something about surprise billing. Nobody should have to deal with these bills. And so we got the No Surprises Act. That said, private equity, even so, there was some dark money behind a major campaign, a major media campaign against the No Surprises bill, and nobody kind of knew who was behind that campaign. Well, from some investigative reporting from the New York Times, they figured out, oh, it was private equity firms that were paying for those media campaigns. But dark money allowed that to be hidden, but eventually they were able to get that to come out. Even after it came out, private equity wasn't in the testimony or the hearings. It was the hospitals, the insurance companies, some advocates, right? They didn't show up because they don't really want to show up in a way, right? But most importantly, around these kind of hidden coalition argument, advocates were fighting for reform, but hospitals, said, okay, yes, we shouldn't have surprise billing. It wasn't very popular to say it's okay to have that. Insurance companies were definitely saying we shouldn't have it, but nobody was implicating private equity. So even the advocates were just saying, yes, we need an act here, we need legislation, but they didn't say we need to do something about private equity, right? Private equity was kind of nowhere in sight in the No Surprises Act. And so we did get legislation. I think people were really happy about this, but when you actually look what was passed, it was very much in favor of what private equity wanted, which was that the decision about the bill, so the bill could still legally be the charges were sort of considered legal and not necessarily appropriate, but legal, but the insurance company was supposed to cover it, and it would go to arbitration over what the amount would be. So the big question was, should there be a benchmark rate that we'd figure out ahead of time what would be covered, what would this benchmark be, or would it go to arbitration? Well, private equity really favored arbitration, and the hospitals favored arbitration, and they would argue that, well, because we have to cover our costs, we don't believe in this benchmarking, the insurance companies wanted benchmarking. Well, arbitration really favors private companies that can lawyer up, right? And so since they passed that bill, you cannot imagine the number of complaints that have gone to CMS about arbitration and the amount of appeals. So it is just mired in appeals, and CMS is completely out of its depth. It has no idea how to deal with all of these claims against CMS for figuring out how to set regulations or guidelines around arbitration.
And the claims are from individual payers or from the insurance companies?
From the hospitals and the PE-backed companies that are involved with these claims, that's saying that this needs to go to arbitration, we're going to appeal it again further, the guidelines around this are not appropriate. So I have kind of a separate paper on that whole arbitration process. But what I'm saying is that what's happening, so I have concerns when we try to deal with the problems that emerge from PE, like nursing homes, again, a good example, we regulate around that particular problem instead of saying, wait a minute, let's think about the role of capital. So Zuri's point is to say, let's regulate PE, which I like a lot, right? So that's a really good place to start. But maybe I shouldn't say maybe, I'll be more bold. I think we need to really just rethink the role of capital and how do we, in our system, right? And government used to provide the majority of capital for our healthcare system, right? Like even hospitals, and I know that's such an antiquated argument because prior to 1965, the largest investor in building hospitals was the government. But in other countries, they do this, right? That they can invest in capital infrastructure because it's a public good, right? And so I just think maybe we need to get back to some 101 considerations about when do we rely on capital markets versus when does government just invest directly in capital infrastructure. And there are little hints that we're moving in that direction with pharmaceuticals, which sounds crazy that I would even say that, but because pharmaceutical prices have been increasing so dramatically, and they are so unrelenting in terms of lack of willingness to negotiate with the federal government, like even around Medicare prices, right, which finally got passed. Some state governments, now I don't know enough about this as I would like just yet, but evidently Massachusetts and California are just starting to consider creating their own kind of pharmaceutical companies around certain pharmaceutical goods to just so that they have control over the production and they can set the price. So it is this sort of, I don't think we ever would have thought that a state government would be willing to move in that direction, but I think they are because they're becoming so fed up with providing the public funding for research and development, not all of it, but a substantial portion of it for pharmaceuticals, having no ability to then negotiate it over prices, and then just losing that control. So I think they want more control over
Lesson
their
to
investments.
capitalists, don't be too greedy. All right, let's turn it over to you guys. Yes, Miranda, let's start with you. Would you introduce yourselves just before you ask your question?
Sure. I'm Miranda Yaver, assistant professor at Wheaton College. So this was a fantastic, fascinating talk, and it's been really fun to see the development of this project since I saw your last presentation of it. Your nursing home example immediately made me think of PE-backed companies that have been buying up behavioral health centers. So the main company that I was thinking of was Universal Health Services, which I don't know to what extent you're familiar with Universal Health Services, but it's bought up at least 100, probably more, behavioral health centers that have been subject to things like patient abuse. They got dragged into the Supreme Court in a False Claims Act. They have I think that case actually was based in Massachusetts. But it also is a really good example of people sort of nibbling around the edges and not really thinking about the role of PE, but sort of thinking, okay, well, we're going to have a DOJ investigation into this abuse incident, or we're going to have a DOJ investigation into this false claim provision. And I was sort of curious to what extent you think that that is an area of healthcare in which you'll look, and also, even though there is this characterization of, well, it's just a few bad apples, well, when it turns out there's a whole lot of bad apples, sort of how do we think about reforming this area where we have serious healthcare shortages, so we don't want to be in the position of shutting down these clinics that are in these PE-backed for-profit companies, but we also don't want to see the perpetuation of these problems.
Yeah. So behavioral health to me is one of the most concerning areas of private equity investment. And it's the reason for that is there's a couple reasons. One is that we're often talking, and behavioral health is a broad bucket, right? But it includes some of the areas they've been particularly interested in investing in is autism, behavior disorder, eating disorders, substance use disorder, opiate use disorder in particular, broadly kind of mental health. But on the eating disorder side, that's always been a largely for-profit business, and private equity moved into that pretty quickly. I don't have much to say about that, but on substance use disorder, especially in the opiate epidemic, it aligns with the opiate epidemic, really, really vulnerable families, vulnerable individuals trying to get coverage, and oftentimes ending up relying on residential care. It might be short-term residential, sometimes it's long-term. That's been another coverage change at the federal level, was to include short and long-term residential care for behavioral health. And that was a pretty major coverage expansion. Most of it's happened through waivers, but anyway, the reason that's so important is that Medicaid for years would never cover residential care. There was an exclusion from that. And people said, well, we have to deal with substance use disorder primarily in the outpatient setting. It shouldn't be inpatient, but sometimes the situation is such that they really need to get stabilized in a residential care facility, and then they can be discharged and go through this whole step-down process. What's scary about that is the number of the residential facilities are just not very well regulated. And there's not a whole lot of oversight in terms of what's happening. It's sort of like the nursing home situation where a lot of abuse
Also
can,
vulnerable people.
right, with very vulnerable people and very little regulation and oversight, and a lot of abuse and neglect can occur. And that's where some of these exposés around residential treatment, they've spotlighted that. But again, they've just done these exposés. So, so I interviewed a guy who was on the finance side of opiate use disorder treatment facilities, and a lot of it is providing Medicaid-assisted therapy to people with opiate use disorder. Hugely important. It's like one of the only ways to get them towards recovery. It's buprenorphine, methadone, etc. He had a whole financial strategy about how to make sure people got their medications, okay? But at the same time, and this, so back to this point about what good can private equity do, he was a real proponent of private equity because he said, our starting, substance use disorder in the US has been so problematic for years and years and years, we can only go in one direction. It can only get better. I don't think, unfortunately, I'm not sure that's true.
Yeah.
But that's a view of a number of people in the field, right? So they kind of welcome that, and it's an infusion of capital. So they welcome it, and you can't really blame them, right? Because they've never had any capital to work with. So they get this infusion of capital to do things like finally have outreach to bring people into their center to provide medications. But then at the same time, you have this finance guy over there saying, well, we need to change the regulations around staff to patient ratios. That's a nursing home strategy, right? And he's like, Minnesota has a better ratio, we're in Tennessee, but we're gonna lobby Tennessee, argue that it works in Minnesota. I mean, they have this whole multi-state strategy to overturn the ratio requirements. Now, maybe when you're just facilitating treatment, a medication, that's okay to let up on the staff to patient ratios, but a lot of evidence suggests that they need counseling, and it's sort of like that counseling is going out the door, right? So anyway, there's a lot to say about behavioral health. The vulnerability and hiddenness of it is what really creates concern.
Let's take a few questions because we're beginning to run out of time, and then you can pick and choose which question you want to answer.
I'm sorry for such long and winded answers.
Yes.
Hi, I'm Andy Ryan. I'm from the School of Public Health. You cited some of my colleagues' research, the investment losses, particularly Chris Whaley, Yashaswini Singh is working on in this area. Appreciate your attention to it. This is my, you choose not to answer it, but this is my question is about, you really strongly motivated the importance of debt in these transactions, how the practices are acquired and the financial deals. And so we are now in a time when debt is much more expensive in our current interest rate environment. And my question is if you think there's going to be kind of a tapering that occurs just like naturally because it's just more expensive for these firms to do these deals in the coming years, and we shouldn't just expect to continue rationing, maybe kind of lie in wait until the interest rate environment becomes more, welcoming. So I'm just curious about your
Interesting. Any get another question or two in unless you're. Yes.
Hi, I'm Maddox. I'm an undergrad at Brown. I'm from Atlanta, and so we've recently had a number of hospital closures in and around Atlanta and Georgia, and they seem to cite this sort of like our profit margins are down as the reason why they're closing. I'm just curious if you think, other than maybe like the state straight up taking over those hospitals when they close, if there is a way to prevent those closures so that we're not down to like 2 hospitals in a major city.
Great. One last one, or shall we All right, Margaret.
Margaret Weir here at Brown. Can you say, this is probably in your chapter 8, but can you say a little more about what happened in the 1980s to make capital so scarce that it became so attractive to both to the PE industry and to the hospitals, et cetera, et cetera?
All right, there's a full cornucopia of questions to think about.
Yeah. On the interest rates, I feel like I'm not the expert to answer that question, so in some ways that's easy. The only thing I wonder about is somebody was just saying to me a couple days ago that high interest rates should be impacting the housing markets, but housing is still really expensive. Why is that happening? It doesn't make sense. So I just put that back to you. Like, the interest rates are not, it seems like with all these new financial instruments, I wonder if there are these situations in which the normal economic models that we have for, like, okay, interest rates go up, these other things should follow from that, don't necessarily follow. And so I don't know the answer to that, but that's just your question to me raised that question again in my own head.
Yeah, I think in the housing market,
Supply.
it's just, I'm exactly in the housing, we're so constrained, we're so underbuilt that the market's still hot, but counterfactual is that it would be much hotter with lower interest rates would be kind of my response. Not that supply and demand aren't working per se, it's just we have this crazy constraint on the supply side.
Right.
Which gets us to Atlanta and the closing down of hospitals. Supply is diminishing.
Right. So, I've been kind of surprised, when I've written about surprise billing, part of my argument was like, well, that was such an egregious example that of course that got on the political agenda. But it took something so horrible to finally get it on the political agenda, right? Like PE was behind this and like, okay, finally get it on the political agenda. I've been kind of surprised that the closure of rural hospitals hasn't had the same story behind it, so that because obviously the congressional members in Congress worry when their local hospital closes. It's hugely concerning. It's not only, really bad for patients who need care and they have to oftentimes travel pretty far distances, not always, but if it's in a rural area. But it's also concerning for the economy of that community. The hospital is always like a major, and this has been true since the 40s. They play a really important role to the economy of small communities. So it's puzzling to me that it hasn't gotten more of the attention because the number of closures just keeps increasing. And I do think there has to be a breaking point, but I'm surprised that I'm still saying that, right?
Yeah.
That it's still happening. So don't have yes, I think they're, so the bailout question is very, very important, so just another, there's I'm forgetting the author's name, do you guys know this book on Ben Taub, the public hospital in Houston? What's interesting about that book is he's a physician, an ER, a physician working for Ben Taub, the largest public hospital in Houston, and he's basically sort of saying, hey, this is a public hospital, and we provide really good care. Nobody would guess. And so he's trying to kind of promote this movement of maybe just straight up publicly owned facilities. It's not as bad as we all thought for so long. Again, just putting that out there, that's something that might arise as more and more hospitals close, and the private markets are just not interested in them. Presumably, we might just have more public, and maybe people would be okay with that. The main thing that, with Chapter 8, what I mainly talk about is how it really was a very important provision in the Medicare. When Medicare and Medicaid were passed, the hospitals negotiated with federal government to make sure that interest and depreciation was covered under Medicare reimbursements to hospitals. And that, I don't have time to go into the details, but that created an incentive for banks to be really interested in providing capital to hospitals because then they knew there was a safe return it made what they previously thought of as hospitals as a risky investment, a safe investment. So that shifted things for hospitals and especially nonprofit hospitals. Nonprofit hospitals could also really take advantage of the tax-exempt bond, and so that's where the state government really came in. State governments issued tax-exempt bonds, and the banks were also very interested in that because of these reimbursement provisions that made it also seem like a good investment.
Wow, which takes you right back to the beginning of your talk and steady reimbursement rates, which makes this all attractive to capital.
Right.
Well, join me in thanking Colleen for a